Okay, so thank you for this opportunity to talk today. It's really my pleasure to talk about nicotine addiction, and I work in the field of genetics, and I'm going to interweave the risk factors for smoking along with the risk factors for lung cancer. So, as we all know, smoking really is a worldwide problem. Over 1 billion people smoke in the world, and that is an equivalent of over 10 million cigarettes consumed per minute. And we have over 5 million deaths per year. In the United States, it's just over 40 million Americans smoke. This number continues to, as a percentage, to go down. But if we look at deaths, the overall deaths are starting to approach 500 deaths in the United States per year. And by far, smoking is the largest cause of preventable death. What's wonderful is that with taxation, we can actually look at per capita cigarette consumption in the United States. And really, we should be thinking of smoking as a 20th century disease. So, examining the per capita smoking consumption, smoking was really not that common at the turn of the 20th century. The increase in smoking really had to do with technologies. As we increased the ability to manufacture cigarettes in a uniform and consistent way, cigarette smoking really took off. We have these clear increases. This one is often considered to be marked by World War I, when the tobacco industry generously provided cigarettes to U.S. soldiers. This steep increase here also corresponds with World War II. Again, the increase of smoking is thought to be related to the, again, in part, the generous donation of cigarettes to the soldiers placed in the C rations. And smoking continued to increase until 1964, when we had the first U.S. Surgeon General's report, which demonstrated that smoking really is related to disease. And we are now celebrating the 50th anniversary of that report. And it's really been a remarkable, I would say, public health success. But if we look at smoking consumption, we had 20 years of a plateau of per capita consumption. And this really had to do with the issues of, we knew that there were issues in smoking, we were educating the public, but it had to do with policies that really came in. And California really drove this with the Clean Indoor Air Acts, and then also taxation coming around. And so then we could see this steady decline. This ended 2010, but we've continued to decrease our consumption of cigarettes in the United States. So again, one of our greatest public health successes of the 20th century, but we are left with our legacy of many diseases, including lung cancer. So when I look at smoking, I think of smoking as a many-step process, and we need to think of it as this multiple steps as we move forward with our public health campaigns. There's never use, the initiation of your first puff, your first cigarette, you develop into a smoker, and then you could become nicotine dependent. Our public health campaigns have really been focusing on this never use step and this transition from a first puff to a never smoker. We've done that through our increase in taxes. We've done it through the removal of vending machines in the population. We have done this with really the limitations of smoking in so many different areas. For example, my high school, amazingly, had a smoking section for the students. And again, these types of things no longer exist. So a wonderful public health campaign. And now what we're really working on is looking at this transition from smoking to nicotine dependence. And what I'm going to say is biology really is driving this step. Environment drives a lot of these two steps, but individual vulnerability drives this transition to whether you're a light smoker or a heavy nicotine-dependent smoker. And we could look at these genetic steps by examining people who are nicotine-dependent. So the standard test for nicotine dependence is the phagosome test for nicotine dependence. And the two key questions that determine nicotine dependence are how soon after you wake up do you smoke your first cigarette? And the people who smoke very early in the morning are very highly nicotine dependent. It's thought to be part of this withdrawal phenomenon that you have. People also report waking up in the middle of the night to smoke a cigarette. So the cigarettes will be right next to the bed, at the bedside table. They get up, they put their feet on the floor, and they start smoking right then. The next aspect is how many cigarettes do you smoke per day? Again, a clear marker of nicotine dependence. And what is been actually very important in the United States is we have been driving down this number of how many cigarettes people can smoke per day just because of all the limitations that we have in restricted smoking in workplaces and inside buildings. So we've done, with the genetic revolution that has occurred, we've done the genetic tests, actually looking at smokers, differentiating them into the low-level smokers and the high-level smokers. We could use differentiating them by how many cigarettes they smoke per day, and we find that there's this strong genetic signal that identifies who becomes a nicotine dependent. So these are the Manhattan plots where you have your chromosomes. Your chromosomes are listed here. This is negative log of the p-value, so a very big number means it's like 10 to the minus 35th. I love the idea that this is called a Manhattan plot, being here in New York City, but I would actually call this a Dubai plot, that we have this extremely tall building that you could see, and it represents this very strong, powerful genetic contribution to smoking behavior. And we could look underneath this signal, and amazingly underneath this signal is a series of nicotinic receptors. So variation in these nicotinic receptors are driving an individual's vulnerability to how much they smoke. So it's the alpha-5, alpha-3, beta-4 nicotinic receptors. We could go on, and we see that underlying this, there is a variant that is causing an amino acid change. It's present in about 35% of populations of European ancestry, and this variant, which changes the protein, changes the risk factor of whether you move from being a light smoker, a person who could smoke a few cigarettes, the individual who says, oh, I just have 2 cigarettes after dinner, versus the individual who's really nicotine dependent, has difficulty quitting, smokes 20 or more cigarettes per day. So with this, the data are now really becoming extremely clear that we have this group of individuals that are genetically vulnerable. They're more likely to convert to daily smokers. When they do become a daily smoker, they're more likely to then transition into heavy smoking. They persist longer with their heavy smoking. So these are the individuals who have difficulty quitting. They are, by all of our definitions, are more nicotine dependent, and they fail in their smoking cessation. So this group, the point I want to really drive home here is not all smokers are alike. We have this group of smokers that are really vulnerable to this heavy smoking aspect and have more difficulty quitting. And that is an important message for our smokers, because oftentimes these individuals feel as if they've failed, that they're unable to quit because they're just not strong-willed enough. And we should be giving this message that some people are more biologically vulnerable and we can treat this. So looking at these slides of per capita cigarette consumption, what really is amazing is we can map onto this the lung cancer death rate in the United States. And we see that really lung cancer is again, I would say a 20th century disease, where lung cancer was rare at the beginning of the 20th century. And then as smoking came about, we've really seen this great increase in lung cancer death rates. The death rates now are, there's this lag of about 30 years between the decrease in smoking and this decrease in lung cancer death rates, but I anticipate that we're going to continue to go down, not only because of improved treatments, but in large part because we've driven down our smoking in the population. So what happened a few years ago is as we were looking for what the genetic predispositions for lung cancer were, many groups across the world did these studies to examine what are the predisposing factors. So these are germline. What are your biologic risk factors, your innate biologic risk factors that demonstrate the risk for lung cancer? And I want to remind you of the Dubai plot that we had of nicotine dependence. And what we see is the same genetic variants that are increasing the risk of heaviness of smoking are by far the strongest genetic risks for lung cancer. I could show you the same types of plots for COPD. So the message behind this is that it's the risk of smoking and the genetics that are driving smoking are the innate biologic predispositions for lung cancer and COPD. In addition, these genetic variants are predicting a 4-year delay in smoking cessation, and importantly now, we see that these same genetic variants predict an earlier age of onset of diagnosis of lung cancer. So if you are going to get lung cancer and you have these high-risk genetic variants, your likelihood of getting these cancer is about 4 years earlier. And given that we're often measuring survival in months with lung cancer, this 4-year shift just by this genetic variance is really quite remarkable. So that's the underlying biology of nicotine dependence and how it relates to lung cancer. But I want us to focus on smoking cessation because really that is our ultimate goal of how do we slay this deadly beast? And what is the clinician to do? So this is really a very controversial field at this point because of multiple new products, but I'm going to go to the areas that I think we will all agree in. And the first is combustible tobacco products are by far the most harmful products out there. So smoking cigarettes, smoking cigars, putting those factors into your lungs is by far the most harmful behavior that we could do. It is best to quit all combustible tobacco products and all smokeless tobacco products. Again, I think we would all agree with that. Unfortunately, we do have sometimes patients who are unwilling to quit. And at that point, I think we have to urge our patients to use as few tobacco products as possible, to reduce their smoking as much as possible. And what you could do is actually have a patient use a tobacco replacement product, and that helps them to reduce. So they don't want to quit, that is fine. They should be consider using a nicotine replacement product on top of their smoking. And it has been shown that that does reduce smoking, and at times patients transition to thinking of quitting. So there's the classic 5 A's that the Surgeon General reports. I've shortened it to 4 A's because I'm into efficiency here. So the first A is ask. We all need to be asking our patients, are you a current smoker, a former smoker, or a never smoker? And really the answers that we should be getting are standard answers in one of these 3 categories. And then, if you are a current smoker, we need to know how many cigarettes do you smoke per day, and how soon after you wake up do you have your first cigarette. I would again recommend setting these specific answers into your forms, into your electronic medical records, and this will give you an idea of how nicotine dependent your patients are. So, if we know that our patients are a current smoker, what do we do next? I think we have to, the next A is advise. And these 2 bullet points in the red are something that should be standardized in every type of setting. And support staff could give these messages. And this is actually counseling at its briefest. One is, it's never too late to quit. This is really an important message for our patients to hear. And quitting is one of the most important things you could do for your health. Those 2 messages are simple, straightforward, can be given by staff, and it's really important for the patient to hear this. So we need to also remember that quitting smoking after a cancer diagnosis is beneficial. If you keep smoking, we know that people may not respond as well to medications. They may not respond as well to chemotherapy. They may have increased side effects from radiation therapy. Surgical complications increase. So it is really important to quit. Often there's this fatalism that I've seen both by patients and by staff of, I have my cancer, it's too late. And we need to really change that message. In addition, if you have cancer, you're more likely, if you keep smoking, to increase your likelihood of a second cancer. So the next A is assist, and with assisting, it's medication and counseling could help people quit smoking, and combined medication with counseling helps the most. So this message is really very important. If a person has been diagnosed with cancer, I think the key thing is we should hit them very hard with smoking cessation. So medications work, counseling works, both are best. And the first line treatments pharmacologically are combined nicotine replacement therapy, so not a single agent, but at least 2 agents, and then varenicline. There's second line, which is single nicotine replacement therapy and bupropion. And then there's a wide range of different types of behavioral therapies that are out there. And I'm going to focus you on the quit line, which exists in every state in the union. So we could arrange, and we could arrange by this 1-800-QUIT-NOW number. So this is an exchange. It's good in every state. And when a person calls this, they are then transferred to their state quit line. This is free, sponsored by several agencies, both at state levels and federal agencies. And with this, we're now approaching over 800,000 calls per year in the United States are going to these quit lines. So this is something that should be on all of our brochures and disseminated to our patients as much as possible. So the controversial point really is the e-cig. There's been tremendous amount of questions about what we should do about this, lots of debates, even in the New York Times, and what should we do? I want us to focus on what is our main goal. Our main goal is to reduce or stop combustible tobacco products. That is our main goal. We all agree that the effects of e-cigs are not known, but I believe we would all agree that electronic cigarettes are probably much safer than combustible cigarettes. And it's this question of how much. I think quite a bit more safer than combustible cigarettes. And what I do know is if a patient uses e-cigs, I think the data are coming out there that their health will be improved if they greatly reduce or quit their combustible cigarette use entirely. So again, this is a substitution. It's not something to be used in addition to their combustible cigarettes. The patient has to know that they have to greatly reduce or quit using combustible products entirely. What are the risks? We're also concerned that young people are going to use e-cigarettes and convert to combustible cigarette smokers. We're concerned that it's going to renormalize smoking behaviors. So now smoking has really become very taboo and very uncommon. And we're all concerned that if if we start embracing e-cigarettes, that we're going to facilitate this longer period of combustibles tobacco use, and we're going to facilitate this transition to combustible smoking. So I just want to end with this slide again. We should be really happy with this decrease in cigarette consumption in the United States, but we still have much to do. We should be pleased. Smoking rates dropped to 17% in the United States. It's the lowest level it's been. I come from Missouri, so right in this area that continues to have very high smoking rates in the United States. But we could see that smoking really has decreased quite a bit along the coasts and in the Great Plains. But we need to help our patients quit now, and it's never too late for them to quit. So thank you very much.